first guest today is Dr. Ryan Donegan, who is an orthopedic surgeon with Bluegrass Orthopedics, correct?
That's it, yep.
Well, welcome. You're going to talk a little bit about shoulder pain, and it seems to be a pretty common thing. At least in our office, we see a lot of shoulder pain.
Yeah.
But when you talk about shoulder, I mean, there's a lot of stuff up there.
Yeah, definitely. I mean, I'd say about 15% of people just, of anybody, struggles with shoulder pain on a weekly basis. So it's actually second to low back pain for the most common musculoskeletal ailment. So it's something that people struggle with pretty ubiquitously. People see it very frequently. So,
are there certain people that are at risk more for shoulder pain?
For me, what I see mainly are degenerative conditions. So it's the patient who's over 45 or 50, maybe the recreational athlete. It's mainly that population I see more than anybody. I think people tend to think it's the athlete. It tends to be the high-performance athlete, but really I think that's actually wrong. It's more patients who are in their 40s, 50s, 60s, and older that most commonly struggle with shoulder pain.
Now, when you say shoulder pain, is there any one thing that causes it, or are there several things?
I would really categorize it into three different common ailments that I see. I think far and away the one I see the most is rotator cuff disease, and that can include tears, it can include bursitis, tendinitis, but that's by far the most common thing that I see. Other conditions commonly that we see are things like osteoarthritis, a little less common than in the knee and the hip, but certainly something that people struggle with pretty frequently. And then the last thing is a labrum tear, which is a collection of ligaments and structures around the shoulder socket that keep the ball and socket stable.
Well, when you get shoulder pain, is there some kind of clue like, oh, this is really something I need to do something with? Or can you just tolerate it and go on?
I think it's about the patient's pain tolerance, their functional deficits. The thing I see most commonly is people having difficulty sleeping. And once it starts to affect sleep patterns pretty commonly, that's when patients present to the physician, whether it be to your office, the primary care physician, and then making that referral over to me. That's a very common complaint I see. And I think if you're starting to struggle with that, that's definitely a time to seek medical attention.
One of the things that I seem to notice is people have chronic pain. They tolerate and tolerate and tolerate, and all of a sudden the shoulder's not moving like it should be. Is there some kind of clue about motion we should pay attention to?
There is such a host of conditions that we see that can affect motion, whether it be things like a frozen shoulder, which patients who have diabetes struggle with. Arthritis can present with loss of range of motion, and then certainly rotator cuff disease can present with weakness and loss of range of motion. So it's really hard to pinpoint exactly what each condition would be based on simple range of motion loss, but if you're struggling with range of motion and pain, that's even more a cause to seek medical attention, whether again to the primary care physician or to someone like myself.
So when they see a doctor, what's kind of the range of treatments, or does it depend on the disease? I
would say that a common misunderstanding is that orthopedic surgeons have a tendency to operate on just a lot of things that walk through the door. And we certainly do a fair number of operations, but I'd say that most patients that I treat are treated non-surgically. And so that can range from things like physical therapy. If you're struggling with stiffness and loss of range of motion, physical therapy is a great place to start, and certainly the family practitioner does a great job in getting people in early to physical therapy. Other treatments tend to be oral anti-inflammatories, things like ibuprofen or Motrin or Advil can work. And then when they make it to my office, it tends to be things like initially like corticosteroid injections, which may or may not help the condition. And finally, when you get to the very late stages and have done a lot of these things that we've spoken about, surgery becomes an option. But it's certainly not the first thing that we think about.
Well, one thing you mentioned a little earlier is a rotator cuff. That's made up of a lot of different muscles and tendons. Tell us just a little bit about that.
There's 4 different muscles that create the rotator cuff, and the function of the rotator cuff, it has a tremendous number of functions. Number one, it holds the ball and socket stable. So we mentioned the labrum, which is a collection of ligaments around the shoulder socket that hold the ball and socket stable. But the rotator cuff, as it fires, as this collection of muscles fires, tends to hold the ball and socket contained on one another. And then when we raise our arms, at certain positions when we raise our arms, that rotator cuff is firing most significantly. But I'll tell you, the thing that I see very commonly that people describe who have rotator cuff disease is things when they're reaching out away from them. So if, for example, if they come to me and say, oh, I had significant difficulty reaching into the refrigerator to get a half gallon or a gallon of milk, or I went to change the station on the radio, you know, reaching out away from you and actually grasping or gripping things and holding it there is something we see very frequently with the rotator cuff, having issues with that.
Well, that's great information. Thanks for coming in.